Hi, this is Brian Kim. I want to share with you this case of a patient with a 2+ dense cataract and an iris coloboma. And you're going to see double chop, cross chop mechanical fracturing techniques. And then I'm going to do a sliding knot suture technique. Normally I would do a single pass 4 through a pupiloplasty, but this is an older case. And so you're going to see the Siepser sliding knot technique and how fairly easily you'll be able to close this iris defect and get a more normal anatomical result. So as you can see, this is the patient. This is the patient's left eye. You can see there's an inferior iris coloboma. That's where they normally are. And this patient also has some posterior synechiae. I use a corneal marker, which will help me to center and size my rhexis. And I make my paracentesis incision, first on the right side and then the left side. This is intracameral lidocaine, and I'm using the lidocaine to lyse the posterior synechiae. And this is intracameral epinephrine, and then some dispersive viscoelastic. This is a triplanar corneal incision. I make a vertical groove, place the blade deep into the groove, tunnel through the cornea, and then when I'm ready, I enter. This is a triplanar corneal incision. So I push some more viscoelastic into the eye. And this is the intramural cross-action forceps here. I'm going to first remove that bubble. I like these forceps because they have a nice sharp tip, which is great for puncturing the capsule. Go ahead and puncture. Sweep to the right to create a little bit of a flap. Grab the right side of the flap. Go around circumferentially. I'm using the corneal mark that I made before, which will help me center and size the rhexis. Especially in this kind of situation, you need that corneal marker to help in center and size the rhexis when you have an eccentric pupil. So I go ahead and finish off the rhexis, burp some viscoelastic out. And this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress on the left side gently, and then point the cannula on the right side, pointing it down. It doesn't really want to move very much here. Some of these iris coloboma cases can have weak zonules, so you want to be very mindful, very gentle as you're spinning the lens. So I went ahead and just swept underneath the rhexis edge a little bit more on the left side, and you saw the lens begin to spin. Irrigate the surface of the cornea, lift the incision with a chopper, go in with irrigation off, minimizing Decimase trauma. Go ahead and remove the surface epinuclear material. Place the chopper under the rhexis edge contra-incisionally. Point the phaco tip vertically sub-incisionally, getting around the lens, crushing it and dividing it. That's double chop, placing the chopper around the right heminucleus, pulling it centrally, meeting in the middle against the phaco tip, crushing the right heminucleus. That is cross chop. Using some vacuum to lift that first quadrant up, and then getting around the lens piece between the instruments, crushing the lens with the instruments, and then emulsifying the lens piece. Getting the chopper around the second quadrant, making sure I get around it, pulling it centrally, crushing it between the instruments, and emulsifying the lens piece. Getting around that second piece of that second quadrant, it's a little bit stuck. Trying to loosen it up a little bit, and then using a little bit of vacuum to lift it up. Loosening it up with the chopper and then using vacuum to remove the lens pieces. So very gingerly and carefully, I'm rotating that second heminucleus, placing the chopper around the lens, pulling it centrally towards the phaco tip. It didn't really go all the way around. Doing the same thing. There wasn't much endonucleus left anyway. So go ahead and grab the epinucleus and it starts tumbling out. heaving the chopper deep. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I'm adjusting the sleeve so it's closer to the phaco tip. Starting subincisionally, I'm removing the cortical material from anterior to posterior. By doing it this way, it's a cleaner peel. Go ahead and switch to polish mode early here because the bag looks pretty clean. And I'm starting to polish the lens epithelial cells off the anterior capsule edge, as well as polishing the posterior capsule. Pull some BSS into subincisional capsule fornix, and then inject some cohesive viscoelastic to fill the bag. Use a sweep to polish under the rhexis edge on the left side and then the right side. You can see this is the older sweeper that I'm using here. Go ahead and inject the single piece acrylic lens into the capsular bag. As the lens unfolds, I use the sweeper to make sure both haptics are in the bag. And now I'm going to draw attention to the iris closure. So these are extra paracentesis incisions, and I believe this is a 10-0 Prolene suture on a CIF4 needle. I'm using micrograspers to help me secure that needle around the first suture side, and then this is the BSS cannula, probably 27 gauge cannula, to help dock the needle through the cannula and externalizing it through that second paracentesis incision. So I go ahead and start pulling the suture. It helps to go to lower mag with these cases. This is a bond hook. I'm hooking the suture on the opposite side, pulling that suture loop through the proximal incision, grasping the loop, making sure I'm grasping the iris side. One side of the loop is against the iris, the other side is going through the contralateral paracentesis incision. I grasp the suture on the iris side and I do 3 throws, grasp the free end of the suture, loop it through, and then you pull on each side, the proximal side and the contralateral side, and as you pull, the knot slides into the eye, and you can see the knot cinched and close the defect. And then you use the bond hook and you do the same thing. You grasp the suture on the contralateral side that's coming out of the contralateral incision. You pull it through the proximal incision, creating a loop, and then you place another suture loop and then cinch it down. Sometimes I'll do 2 loops just to secure it. You don't really have to do 1. You can do 2. It's not really going to be detrimental for this type of suture closure since it's just 10-0 nylon. The only thing you have to worry about is getting tangled. Sometimes the loops get stuck in viscoelastic, and if that happens, just pulse some BSS on the suture, and that helps get rid of that viscoelastic, and you can make your loop again. So you loop it, and then grasp the free end of the suture, pull it through, and then pull on the contralateral side. The knot slides in, and it cinches down. So that was 3 suture loops I've made. I'm going to go ahead and pass another suture using the needle and the BSS cannula. Again, it's a 27 gauge cannula. Passed it on each end of the iris defect, and then using the cannula as a guide, docking the needle through the cannula tip and then pulling out on the proximal side of that incision. Grabbing the suture on the contralateral side, looping it through the proximal incision, grabbing the side that's on the iris side with my left forceps first, and then making 3 loops but as I did that, I realized I pulled the suture through. So using a handshake technique, I went in with the left hand, grasping the suture within the anterior chamber, and then the right hand with the handshake technique, pulling the suture back out. So with this technique, you want to make sure you have enough suture coming out of the contralateral side, because when you loop it, you lose some suture. So I'm looping, pulling the loop through, pulling down on the free end on both sides, the proximal and the contralateral side, and as you pull, the knot slides into the eye. And you just repeat the same steps. So again, like I like to do is use my left hand to hold the loop that is closest to the iris side, and on the right side is the suture is the free side. And so again, you like to make 2 loops. You want to go backhand and overhand and then alternate each way so you get square knots. And even with these, instead of doing 1, I like to do 2 loops. And then you're going to, using the left forceps, giving and handshaking the suture end to the right side, pulling both sides, pulling both free ends. The knot slides into the eye and then it cinches down. We do the same thing. This will be the 3rd loop, using the bond hook to grasp the suture on the contralateral side, pulling the loop through. Again, making 2 throws, grasping the free ends, and then pulling it, and then the knot slides in. Using microforceps to cut the excess suture material, going back to higher mag, and that's the closure. So go in with irrigation off, activating irrigation, going underneath the lens to remove the viscoelastic from within the bag. You can see there's a really nice suture closure. It's very secure, it's not coming undone. Go ahead and polish underneath the rhexis edge here. And then going to visco mode, removing the viscoelastic from the anterior chamber, and then I'll hydrate my incisions. So again, this is a patient with an iris coloboma, a 2+ dense cataract, performing double chop, cross chop, mechanical fracturing, using the Siepser sliding knot technique to close the defect. Again, a single pass 4-throw pupiloplasty would have been a much faster way to close the defect. But again, this is an older video, like I said. And as long as you do it systematically and you do overhand throws and then backhand throws, alternating, and you can't do too many throws. You know, you can do like a 3-1-1, but as you saw in the video, I would do like a 3-2-2, just to be on the safe side. Again, a little bit more work doing it this way, a little bit longer, and single pass 4-throw is really kind of a faster, more efficient and elegant way to close. But nonetheless, this patient had a really nice result, and the patient did well. So I hope this was helpful to you, and I thank you for your attention.